Hello guys, welcome back to my channel. Before we even start, I want to apologize for uploading this video late. I have been so busy preparing my own exam and getting ready for Thanksgiving. So happy Thanksgiving ahead of time to you guys, and let's dive into it. In today's video, we're going to talk about a very interesting topic, the tricyclic antidepressant. Like the name suggests, they are used to treat depression. So what are tricyclic antidepressant? Is a vast group of medication. They have many indications that we are not going to dive into it. We're just going to touch base light on their basic for the purpose of this video. So inside the tricyclic group, you have a subcategory that are called secondary amines versus tertiary amine. They are all tricyclic. I'm not going to go into the deepest of it, but I'm just going to give you some name that you can know and remember and know that these are tricyclic. So you can have amoxapine, doxapine, amitriptyline, nortriptyline, diazepamine, and much more others, but these are just the basic one. By knowing this basic, you can recognize the order because they will sound alike. Now let's talk about their mechanism of action. So inside your brain, tricyclic are going to inhibit the reuptake of serotonin and norepinephrine. So by inhibiting the reuptake of those two, it's going to increase the level of serotonin and norepinephrine inside your synaptic cleft. Now remember, like all antidepressants, it takes about 6 weeks to see the therapeutic effect. So it's the same for tricyclic because they work on a long term. So it takes those 6 weeks for these receptors to be down-regulated. So remember, we have every time that you give an agonist to your body, it down regulates your receptors. And every time that you give an antagonist, it up regulates your receptors. So this is going to be the same thing for tricyclic. So after 6 weeks of a patient taking this group of antidepressant, the receptor to serotonin and norepinephrine is going to be down regulated, and this is the main mechanism on how they have this antidepressant therapeutic effect after 6 weeks. And also, tricyclics are going to block the sodium channels. So remember, the sodium channels are very important in the action potential of your heart. I did upload a video about the action potential on the heart. If you haven't watched it, please do so. So basically on the phase 0, this is the phase where the fast sodium channel open and go in, and the sodium gets inside your myocyte, and this is how you have your depolarization at that phase. So if the tricyclic inhibit that phase, so we're gonna see how we're gonna have a lot of cardiac interaction with these drugs, and we're gonna talk about it later. And these tricyclic also are gonna inhibit your histaminic 1 receptors. So they're going to act as antihistaminic 1, and histaminic 1 receptors are mainly in your brain. We have different type of histaminic receptors, but these receptors 1 are mainly localized in your brain, and they also participate into the anti-inflammatory response. So tricyclic are also going to block this antihistaminic 1. So they're going to have antihistaminic 1 activities. Also, they're going to also inhibit your muscarinic receptors. Remember, acetylcholine presynaptically bind to your nicotinic and postsynaptically bind to your muscarinic receptors. So because they're going to inhibit your muscarinic receptors, they're also going to have a lot of interaction with our anesthesia related medicine. So we also going to talk about it. And they also going to block your alpha-1 receptors. Remember, alpha-1s are more localized in the vessel. So by blocking these receptors, we're also going to have things like hypertension, but we're going to get to it. So tricyclic antidepressant is a class that is structurally related to your local anesthetic. No wonder they block the sodium channel. So they're gonna have a lot of interaction with your local anesthetic. Tricyclic is also related to your structurally related to your phenothiazide. Phenothiazide is a psychotropic drugs, so they are potent dopamine 2 antagonists blocking at their receptors, and we're gonna see how this translates into the side effect of tricyclic. So this is a vast group. To just let's just recap of their mechanism of action. They're gonna block the reuptake of serotonin and norepinephrine. They're gonna block the sodium channels. They're gonna block alpha 1 in your vessel. They're gonna have antimuscarinic activities, and they also gonna have antihistaminic 1 activities. So these are six receptor blockade, so you can understand why they're gonna have a lot of interactions. So now let's talk about their metabolism. Like many antidepressants, they are highly protein bound, so we're gonna have a lot of interaction with our high protein binding drug. Just like last week we talked about our anti-epileptic drug, we saw that carbamazepine, phenytoin, valproic acid were very high protein bound. When we talk about diuretic, we saw that furosemide is high protein bound, and also warfarin. So tricyclic or this protein bound, they're gonna maybe displace each other and increase the toxicity of each other. Tricyclic also, like many antidepressants, are CYP450 inhibitors. So remember, we talk about in anti-epileptic drug, we talk about valproic acid, which was a potent CYP450, and because tricyclic is also metabolized by CYP450, especially called CYP2D6. So these drugs are gonna the inhibitor of those CYP450 category are going to increase the level of tricyclic in your body. So tricyclic, they are metabolized in the liver like many other antidepressants. They're going to have a lot of interactions. Also, tricyclic are highly protein bound, like we just saw. Now let's talk about their adverse effect. So when we talk about tricyclic, we want to think about CNS, heart, and anticholinergic activities. So this is how we're going to list their adverse effect. In the heart, because they're going to block this sodium channel, we're going to have, and also they are alpha 1 antagonists, we're going to have a lot of hypotension. This is their main side effect, and tachycardia. Tachycardia might be reflexive to the alpha 1 blockade. Hypotension also to the alpha 1 blockade, to the muscarinic 1 blockade, and antihistaminic 1 blockade. So hypotension and reflexive tachycardia is the main side effect of tricyclic in the heart. But if you give tricyclic a high dose, you also gonna have a conduction abnormality. They're gonna slow your AV node. So this is gonna be depicted by prolonging your PR interval. You're gonna have like slow amplitude of your T wave. You're gonna have a long QRX complex greater than 0.12. So these are all gonna do to tricyclic, and at high dose they can increase your risk of torsade. So we also have other drug and psychotropic drug that also increase your risk of torsade, so you don't want to give them together. Drug like haloperidol, droperidol, they increase your risk of torsade, and we use droperidol a lot in anesthesia for nausea and vomiting, so you don't want to give them together. Now let's talk about the CNS adverse effect. Tricyclic is going to decrease your seizure threshold, so it's going to give you a lot of risk of seizures. And other antidepressant that does it is going to be bupropion. Bupropion is an antidepressive drug that is going to inhibit the reuptake of norepinephrine and dopamine. It's used for smoking cessation and weight loss. Bupropion is going to be the first at giving you this kind of seizure-related side effect, followed by the tricyclic and other antidepressant. So in your CNS too, it's going to give you a lot of sedation. Amitriptyline is the most sedative of this class, and diazepam is the least sedative. Now that we touched about the CNS, now let's talk about your anticholinergic side effect. Anticholinergic side effect is gonna, you can pee, you can use the bathroom, so it's gonna it's gonna dry up your secretion. You're gonna have a slow motility in your GI, and it's gonna increase your intraocular pressure. Remember, drugs like dopamine, phenoldiazepam also increase your intraocular pressure, but other drugs like timolol, acetazolamide, we saw it when we were talking about diuretics, osmotic diuretics, they all gonna decrease your intraocular pressures. So so tricyclic antidepressants are potent anticholinergic drug, and this is why you also gonna have like depression, like, and delirium in your elderly patients. So you want to be cautious when you give this to elderly patients. Now let's talk about their main interactions. So tricyclic interact with a lot of drugs. But like I said, we are not going to go in the deepest of this, or we're just going to touch base on the interesting facts. So tricyclic with your opioid and barbiturate. Because tricyclic gives you depression, you want to decrease your dose of opioids and barbiturate because they're going to be additive to the depression side effect. With your inhale anesthetic, like you have like Sevo, your Dex, it's gonna further the hypotension because these anesthetic are gonna give you hypotension. Tricyclic main side effect is orthostatic hypotension, so it's gonna further your hypotension, especially if your patient is not hydrated sufficiently. So you want to check also on the fluid status of your patient. Now, with your other antidepressants, so if you give tricyclic with your SSRIs, your selective serotonin reuptake inhibitor, because these are too high protein drugs, it can increase the risk of bleeding, so you don't want to give them together. And also because both of them increase serotonin into your synaptic cleft, they can give you serotonin syndrome, so be aware. Now SSRIs and bupropion that we talk about, they are also CYP450 inhibitors that are going to increase the level of tricyclic. So if you, let's say you give your tricyclic with bupropion, increase seizures, increase level of tricyclic, a lot of toxicity. So you want to stay away. And with your tricyclic and your monoamine oxidase inhibitors, like seleginate, you want to stay away because it can give you the risk of hypertension crisis. Because remember, your monoamine oxidase inhibitor is going to increase all these neurotransmitter in your synaptic cleft like dopa, epi, norepinephrine. So, and adding that to the tricyclic, increasing norepinephrine, yes, hypertension crisis is at the door. Please never give them together. Now, with your anticholinergic CNS, so because we saw that tricyclic has anticholinergic property, so if you give them with other anticholinergic drugs that are highly lipophilic to go on in your CNS, they're gonna give you a lot of depression and post-op delirium. So anticholinergic that are highly lipophilic includes atropine and scopolamine. So you don't want to give them together. But other drugs like glycopyrrolate is also anti-muscarinic that can act to a lesser extent to your CNS. It's not going to cause you a lot of post-op delirium. Now, if you give tricyclic, if your patient is taking tricyclic and you are doing the induction of your anesthesia, I just want to say that tricyclic, they have a very long half-life. So if your patient is on regular tricyclic and it comes for surgery, is highly it's highly preconized that you look at these interactions because they have a long half-life and it's going to still be in their blood system by the time you do your anesthesia induction. So if you do your anesthesia induction and you have AP, even if it's the least amount of AP, it's going to increase your risk of cardiac dysrhythmia. So just be aware. Now, if your patient is taking clonidine and abruptly withdraw, remember clonidine is a partial agonist at alpha 2 receptor in your brain. Because alpha 2 agonists decrease norepinephrine, we use it for hypertension. So if you abruptly discontinue your clonidine, you have that rebound hypertension. And now if you add a tricyclic on top of it that increases the release of norepinephrine, yes, that rebound hypertension crisis is going to be huge. So you don't want to do that. Now, with your anesthetic drug, like your non-depolarizing neuromuscular blocker, like pancuronium, is going to increase the risk of dysrhythmia. Tricyclic increase the risk of a lot of risk of dysrhythmia because of its sodium channel blockade action. So you really want to check your EKG when your patient is on tricyclic. Now, let's talk about with your sympathomimetic drugs. Now, if your patient just started on tricyclic, remember, they achieved their antidepressant therapeutic effect by 6 weeks. So this is when the receptors are downregulated. But if they just started, those receptors are not downregulated yet. So you're going to have an increase in your norepinephrine inside your synaptic cleft. So if you give your sympathomimetic drug, you're going to have a huge potentiation. So you don't want to give that. So if you even have to give, don't give mixed acting like ephedrine. Ephedrine, even though it's a mixed acting, it acts more as an indirect acting, increasing the release of those norepinephrine. So it's going to be huge with ephedrine. So if you have to give a sympathomimetic to your patient on tricyclic, give the direct acting, but cut the dose into a third of the normal dose. Now, if your patient has been taken for more than 6 weeks, those receptors are already downregulated, so you can give both ephedrine and your direct acting like norepinephrine, epinephrine, but you just have to cut the dose into 1/3. And if your patient is taking it chronically, like over years, now you know that definitely those receptors are very, very much sleeping. So the only thing that you can give for your sympathomimetic is going to be a direct acting like norepinephrine to these receptors, because those receptors are going to be knocked out. Now, let's talk about other CNS depressant like meperidine. You're going to have a lot of side effect. You can have rigidity, you can have serotonin syndrome, you can have hyperpyrexia, so you don't want to give them alone. And also with tramadol is a current use drug, and actually it's a friend of mine that pointed this interaction, and I found it so interesting because tramadol is going to do also the same thing. It's going to increase your norepinephrine and serotonin in your synaptic cleft, and it's going to give you a huge risk of serotonin syndrome and sympathomimetic activation. So you don't want to give them together. Although tricyclic is not addictive, it can give you withdrawal syndrome if you abruptly discontinue it. So you're going to have signs and symptoms like chills, malaise, muscle aches, fatigue, GI disturbance, so you also want to taper the dose. So now, if you give tricyclic, if you overdose tricyclic, you're also gonna have the same adverse effect category but more amplified. So if you give tricyclic and the patient overdose, you're gonna have like CNS signs, adverse effect. Your patient is gonna be in seizures. So you can give drugs like phenytoin to control that seizure. Remember phenytoin again? I uploaded a video about phenytoin use as anti-epileptic drug. So if you haven't done so, please go and watch it out. It's interesting. And also you can give benzodiazepine to control the seizures. And for you're gonna also have a lot of cardiac dysrhythmia if you overdose of phenytoin. Remember, they block the sodium receptors. So for those cardiac dysrhythmia, you can also give phenytoin. And you can also give lidocaine because they are also classified as 1B anti-arrhythmic drug. I uploaded a video about digoxin and I talk about why phenytoin and lidocaine are good for ventricular dysrhythmia. Please, if you haven't done so, do it. And also remember, you're gonna have your anticholinergic activities, so your treatment is gonna be really supportive. You're gonna do cooling measure, a lot of fluids, and control your patient. So this is just what I have. It's a very, very basic thing. Please, this is not, this list, what I spoke about is not completely inclusive. It's very little to know. If you want to know more, please dive into books and research articles. And thank you for watching this video. I will see you on my next video.